Record progress.
So this is my second part to the anemia topic. My name is Dr. Amartej Singh Deol, and I'm an ACE Med Boards tutor. From all my step one students, I remember myself struggling, not knowing where the light was at the end of the tunnel, but every single day I made sure to put determination, hard work, and perseverance. I didn't just say these words, I put them into action. And I soon started to see the light. But what a lot of people don't realize is the tunnel didn't get shorter. I crawled out of that tunnel. So I know you could do it. Just believe in yourself, make your belief stronger than your doubt, and we'll get there together, okay? So what is hemoglobin? Heme synthesis, okay? Heme plus globin equals hemoglobin. Heme is made of iron and protoporphyrin. So what is protoporphyrin and how does that synthesize? So first, we'll start off right here in the mitochondria. This is very important to know if it's in the mitochondria or the cytosol because they can ask you which enzyme is in which location. So this is important. So there's a couple enzymes that are important and we'll talk about them, but we'll just overall go through the whole thing. So there's glycine and succinyl-CoA, and what that gets to aminolevulinic acid, ALA, through ALA synthase and B6. Remember, sideroblastic anemia, if you don't have B6, you could get that. Sideroblastic anemia from here. So aminolevulinic acid goes to porphobilinogen, so it leaves the mitochondria via ALA dehydratase, and that's porphobilinogen, okay? Porphobilinogen is then made into hydroxymethylbilane through porphobilinogen deaminase. And these two enzymes are very important because they're going to be about some diseases that we're going to come up if they're deficient. Uroporphyrogen third goes to coproporphyrogen the third through uroporphyrogen decarboxylase. Copro goes back into the mitochondria and it creates protoporphyrin. Here is the final synthesis of heme, where iron and protoporphyrin with the enzyme ferrochelatase convert to make heme, okay? Lead inhibits ALA dehydrogenase and ferrochelatase, okay? So what is a porphyria? It's a hereditary or acquired condition of defective heme synthesis that led to the accumulation of heme precursors. So actually, let's take a look back at this. So if we're deficient in porphobilinogen deaminase, is hydroxymethylbilane going to be increased or decreased? Good. It's going to be decreased if we're deficient in this enzyme right here. How about if we have a deficiency in uroporphyrogen decarboxylase? Is coproporphyrogen going to be increased or decreased? Good. It's going to be decreased. And uroporphyrogen, the third, will be increased. Hydroxymethylbilane will be increased. Porphobilinogen will be increased because it's accumulating because it can't go through the full process. Okay? So lead inhibits specific enzymes in heme synthesis leading to similar conditions. And we just talked about those, right? ALAD and ferrochelatase can cause severe pain in the abdomen, chest, legs, or back, constipation or diarrhea, nausea and vomiting, hematuria, palpitations, and increased blood pressure. So now lead poisoning. Affected enzymes, like we said, were ferrochelatase and ALA dehydratase. The accumulated substrate is protoporphyrin and ALA in the blood. Symptoms: microcytic anemia, basophilic stiffling in the peripheral smear, ring sideroblasts in bone marrow, GI and kidney disease, and the children, they'll be exposed to lead paint and they'll have mental deterioration. Adults will have environmental exposure, examples like batteries or ammunition, and they'll have headache, memory loss, and demyelination, which is peripheral neuropathy. Acute intermittent porphyria. Affected enzyme is the porphobilinogen deaminase. This is an autosomal dominant mutation. The accumulated substrate is porphobilinogen and ALA. And this is the 5 Ps with this porphyria. Painful abdomen, port wine colored pee, polyneuropathy, psychological disturbances, and precipitated by the factors that increase ALA synthesis, like drugs, CYP4, cytochrome P450 inducers, alcohol, and starvation. The treatment is hemin and glucose. Porphyria cutanea tarda. The affected enzyme is uroporphyrogen decarboxylase. The accumulated substrate is uroporphyrin, which is a tea-colored urine. Presenting symptoms are blistering, cutaneous photosensitivity, and hyperpigmentation. Cutaneous, right? Most common porphyria, exacerbated with alcohol consumption. Causes are familial and hepatitis C. Good to know that correlation. Treatment is with phlebotomy, sun avoidance, antimalarials like hydrochloroquine. Okay. So now back to microcytic anemia. Here, why does microcytosis occur? First off, we've discussed this a little bit in the previous video, but we'll definitely go through it again. Something is wrong with the hemoglobin. Heme is made up of iron and protoporphyrin, and globin is made up of alpha and beta chains. Erythroblasts start off large, but as they divide into mature red blood cells, the cells will get smaller and smaller. If there's a problem with the iron, protoporphyrin, or globin chains, hemoglobin production will be decreased. This will cause the RBC to try to maintain the proper amount of concentration of hemoglobin. The cell will divide one extra time to try to maintain the concentration of hemoglobin. Here we can see up here at the top, there's iron and porphyrin combining to make heme synthesis with the alpha and beta globin chain to make hemoglobin, right? So microcytic is MCV less than 80. We talked about the 4 types. There's iron deficiency anemia, anemia of chronic inflammatory disease, thalassemia, and sideroblastic anemia. So the biochemistry of iron, this is very important, okay? It's consumed in heme products, which are meat-derived, more readily absorbed, or non-heme products, which are vegetable forms, okay? Absorption of iron occurs in the duodenum. Enterocytes line the gut, and they transport iron into the blood via ferroportin from the lumen of the gut, right? So you eat the food, the iron comes, and it gets absorbed through the enterocytes, and then the port that allows it to go in the blood, ferroportin, will decide, does the body have enough or does it need more? And then it'll allow the iron to come in. Once the iron is in the blood, it needs to be picked up because it could cause oxidative damage because it's a very damaging molecule, iron is. And so transferrin picks up the blood, or excuse me, it picks up the iron in the blood and transports iron to the liver and bone marrow macrophages for storage. This stored intracellular iron is bound to ferritin. Ferritin is what keeps it inside the storage sites, okay? It prevents free radical formation. Iron in blood will always be bound to transferrin. For every 3 transferrin molecules, 1 iron will be bound. So that makes the normal percent of saturation of iron bound to transferrin is 33%. Okay, so here's another example. This is the lumen. So you ingest the iron, and then it comes in and goes into the enterocyte. Okay, and there ferroportin will allow the iron to come in to the bloodstream, and if it does, then transferrin will pick it up and it'll take it to the bone marrow or the liver macrophages, okay? And it'll be stored in as ferritin. Lab measurements: serum iron measures how much iron is in the blood. TIBC is how many total transferrin are in the blood. Ferritin is how much is present in storage side, in ferritin in the storage. Liver and bone marrow macrophages. The percent saturation is how many transferrin are bound to iron. Remember, it should be a normal saturation of 33%. For every 3 transferrin, there should be 1 iron bound to one of those molecules. The general rule is whenever ferritin decreases, TIBC will increase and vice versa. Okay, this is important. The red blood cell distribution width, the RDW, it checks the spectrum of sizes of RBCs. We want our RBCs to all be normal sizes, okay? Normally the RBCs should be the same size. A wide spectrum of RBC size will increase the RDW, and it shows abnormality of the RBC. So the first microcytic anemia we'll talk about is iron deficiency anemia. It's the most common anemia. It's most common nutritional deficiency in the world. Up to 1/3 of the population is deficient in iron. It's due to decreased levels of iron in the body. Deficiency caused by dietary or blood loss. For infants, is due most commonly to breastfeeding. Child is poor diet. Adults have a peptic ulcer that might be bleeding. Adult females is pregnancy or menorrhagia. Elderly, colon polyps, carcinoma, especially in the Western society. And then in developing countries, hookworms are a big cause, like Necator and cyclostoma. Other causes are malnutrition, malabsorption, gastrectomy, or PPI. Gastrectomy and PPI are causes because in normal state, the acid keeps iron in the Fe2 plus state, which is more readily absorbed. Fe2 into the body. Fe3 plus is not as absorbed. Fe2 plus into the body, right? And the acid helps keep that. So anything that's stopping the acid would decrease the bioavailability of iron. Stages of anemia. So first, when we're starting to become anemic with iron deficiency anemia, the storage iron is depleted. So the ferritin will go down first, right? The serum iron second is depleted, and that will show us decreased serum iron. The third thing that happens is initially in iron deficiency anemia, I know it says microcytic, but initially we have normocytic anemia. It will sacrifice the total amount, the body will sacrifice the total amount of red blood cells to have a normal shaped RBC. But as we keep losing iron, then it will eventually become microcytic hypochromic anemia. It's an ability to produce the normal red blood cell. There will be central pallor of the RBC will expand, and it will not have the nice red color that the hemoglobin produces. The clinical features of iron deficiency anemia are anemia, colonychia, which is spoon-shaped nails, and pica, which is the psychological drive to get iron from any source possible. So you chew on things abnormally like sand, ice, anything. So lab findings: microcytic hypochromic anemia with increased red blood cell RDW, a decreased ferritin, increased TIBC, decreased percent saturation, decreased serum iron, and an increased free erythrocyte protoporphyrin. The reason for that is because, and remember, heme is made up of iron and protoporphyrin. The protoporphyrin has nothing wrong in iron deficiency anemia. It's the iron that's deficient. So protoporphyrin will end up being free because it can't bind to the iron to make heme. Treatment: supplemental iron, ferrous sulfate, and treat the underlying disease if there is. And here's a subtype of iron deficiency anemia that's important. Plummer-Vincent syndrome is where they'll have anemia, dysphagia, and beefy red tongue because of their iron deficiency anemia. Esophageal webs are causing blocks essentially in the esophagus, and this is why they have dysphagia. And then atrophic glossitis is beefy red tongue. So now, anemia of chronic inflammatory disease. It's associated with chronic inflammation or cancer. The most common type of anemia in hospitalized patients. The chronic inflammation will lead to increase in acute phase reactants. One acute phase reactant is hepcidin, which will sequester iron into storage sites. So if the body notices there's a lot of inflammation, it will produce APR, hepcidin, and this will stop the bioavailability of iron for the body. It suppresses EPO production. It limits iron transfer from macrophages to erythroid precursors. And the reason why it does this is because iron is an essential nutrient for bacteria to survive. The body doesn't know what the inflammation is due to. It thinks the inflammation is due to a microbe, so the APRs are increased. Labs: there'll be increased ferritin because of the hepcidin causing the sequestration of the iron, decreased TIBC, decreased serum iron, decreased percent saturation, and they'll have the same stages as iron deficiency anemia. Treatment: you have to treat the underlying cause and then EPO exogenously, especially in cancer patients. Now we'll talk about sideroblastic anemia. It's a decreased protoporphyrin leading to microcytic anemia. Is due to defective protoporphyrin synthesis, right? So normally a series of reaction occurs. Final reaction attaches protoporphyrin to heme, iron to make heme. This occurs in the mitochondria. While protoporphyrin is being synthesized, iron is being transferred to the erythroid precursor and enter the mitochondria to form heme. If protoporphyrin is deficient, then iron remains trapped in the mitochondria and heme cannot be formed. More iron will pile up and get trapped in the mitochondria. It creates a ring of iron overload around the nucleus called a ring sideroblast. You will see this with a Prussian blue stain. Iron overload in the mitochondria and cell will eventually create free radicals and damage the cell, releasing the iron. So this could be acquired or congenital. Congenital cause is most likely due to ALAS enzyme, and acquired is usually due through alcoholism, which damages the mitochondria and could damage protoporphyrin production. Lead poisoning, which denatures the enzyme, specifically ALAD, and it's important to know that's in the cytoplasm, and ferrochelatase, which is in the mitochondria. Also, vitamin B6 deficiency, which we spoke about, required with ALAS, and some medications could actually decrease it, like isoniazid, and B6 is required with isoniazid for tuberculosis treatment. Labs: iron overloaded state. So the serum iron will be increased due to the rupture of the cells from the iron overload in the mitochondria. The ferritin will be increased. Macrophages will eat the released iron from damaged cells. The percent saturation will be increased, but the TIBC will be decreased. So here's another picture of that image. Thalassemias. It's the decreased synthesis or production of globin chains of hemoglobin will lead to the anemia. It differs from the other diseases where there's abnormality in the globin chain after it's produced. Example, sickle cell. Here it's a problem with the production. The other ones are after they're produced. It's a defective chain, not decreased synthesis of it, as in the case of thalassemia. So inherited mutation. It's protective against Plasmodium falciparum malaria, is divided into alpha and beta thalassemias, is based on decreased production of alpha or beta globin chains. All hemoglobins use alpha chains. There are 4 copies of alpha gene. There are 2 copies of beta chain. And on here, we'll see target cells. It's important to know what a target cell is. Normal red blood cells are biconcave and their edges are thicker and contain more hemoglobin. The center is thinner with less hemoglobin. Target cells occur when there's an increase in the membrane or decrease in the cytoplasm. In thalassemia, we'll have a reduced hemoglobin in cytoplasm, which allows a membrane to produce a bleb. Hemoglobin will go into the bleb and create a red center in the center of the cell, aka the target. So beta thalassemia is due to gene mutation. There's 2 beta genes that are present on chromosome 11. Mutation results in beta absent, which is beta null, or diminished, which is beta plus productions of globin chains. There's 2 major subtypes, which are minor and major beta thalassemias. There are many others, but these are the ones that we'll be discussing. So for beta thalassemia minor, one beta is normal, and then there's one that's null, which is not producing. Mildest form of the disease is usually asymptomatic with increased red blood cell count, and it will show a microcytic, hypochromic, RBC, and target cells on blood smear. Electrophoresis will show slight decrease in HbA, an increase in hemoglobin A2. Normally it's 2.5, but here will be increased to 5%, and an increase in hemoglobin F to 2%, which is normally 1%. In beta thalassemia major, it's the most severe form of disease. Severe anemia a few months after the birth. HbF at birth, hemoglobin F at birth is temporarily protective. Alpha tetramers aggregate and damage the RBC. So there'll be ineffective erythropoiesis, extravascular hemolysis, damaged RBCs as they are generated, and the spleen will recognize abnormal RBCs and destroy them with splenic macrophages. We'll get massive erythroid hyperplasia. So here in the labs, we'll see no hemoglobin A because there's no beta chains being produced. We'll see a major increase in hemoglobin A2 and hemoglobin F. The blood smear will show microcytic, hypochromic, target cells, and nucleated RBCs. Treatment, chronic transfusions. The side effect, though, is secondary hemochromatosis. Massive erythroid hyperplasia. Expansion of the, so what does that mean? We saw that here, massive erythroid hyperplasia. What does that mean? It's expansion of the hematopoiesis into the marrow of the skull and facial bones. It's extramedullary hematopoiesis with hepatosplenomegaly. Hematopoiesis and erythropoiesis usually occur in the central axial skeleton, especially as we age. Babies have erythropoiesis throughout the body. Massive hemolysis will respond with increased EPO from the kidney. Bone marrow will undergo hyperplasia. And the skull, you'll see a classic sign of crew cut on the x-ray. And the facial bone, you'll be able to see a chipmunk-like faces. And here we'll have a risk of aplastic crisis with parvo B19. And thalassemias are dependent on every RBC that would be at risk with B19 virus. So now we'll discuss alpha thalassemia is due to gene deletion. Normally 4 alleles are present on chromosome 16. Knocking out alpha genes will lead to symptoms, okay? So scenarios: 1 gene deleted, asymptomatic; 2 genes deleted, mild anemia with slightly increased RBC count. The cis deletion is worse than the trans deletion, risk of passing off severe anemia to offspring. 3 genes deleted, severe anemia. Beta chains form tetramers, HBH, beta 2, that damage the red blood cells. HBH is seen on electrophoresis. There's no problem in utero because of the hemoglobin F. But if you have 4 genes deleted, it's lethal in utero. This is called hydrops fatalis. There's gamma chains that form tetramers. This is called HB BARTs, and this will damage the RBCs. This is non-viable life right here. Macrocytic anemia. Anemia, but RBCs are bigger than normal. MCV is greater than 100. But the question is, what is driving the cells to be so large? There's major causes that deal with DNA precursors such as folate and B12. Immature precursor erythroblasts divide continually until mature red blood cells are formed. Every time a cell divides, it needs DNA precursors. Disruption in DNA precursors due to deficiency or acquired defect will not allow the cell to divide properly because it doesn't have the necessary precursors to divide. Hence, one less division, making larger cells, aka macrocytic. Macrocytic means big cells alone. It doesn't mean megaloblastic. Megaloblastic means there's impaired DNA synthesis and hypersegmented neutrophils. Non-megaloblastic means it does not have to do with the impaired DNA synthesis, and there's less than 5 neutrophils. Less than 5 lobes in the neutrophils. So how does folate and B12 help DNA synthesis? So this is very, very important. And this is why we'll see an increase in homocysteine in B12 and folate deficient patients. So when tetrahydrofolate comes into the body, it is quickly methylated in order for, so right here, we can see right here, this comes into the body and it's methylated. So it's methylated THF. In order for the folate to be used for DNA synthesis, it must lose the methyl group. So here's DNA synthesis, and here we can see it's unmethylated. So how does it do that? Well, tetrahydrofolate convinces vitamin B12 to take the methyl group from THF. Then tetrahydrofolate is free to go to help with DNA synthesis. So here we can see cobalamin, which is B12. It's normal at first, and then 5-methyl tetrahydrofolate convinces it to take the methyl group. So now we have methylcobalamin and a free THF. Vitamin B12 recognizes that it does not like the methyl group and passes it on to another molecule. It passes the methyl group to homocysteine, and that converts it to methionine and frees up B12 for the next tetrahydrofolate that needs to be methylated. So here we see the methylcobalamin, and here we see homocysteine take that methyl group with methionine synthetase and now turns into methionine, okay? And that's took the methyl group and turns homocysteine to methionine. If vitamin B12 or folate are deficient, this all cannot occur. And if this all can occur, homocysteine will be the one that builds up because it can't convert it to methionine. So macrocytic anemia, here we have folate deficiency. It's the most common cause of macrocytic anemia. Folate, it's obtained from green vegetables and some fruits. It's absorbed in the jejunum. Folate deficiency develops within months. Causes: poor diet, alcoholics and elderly, increased demand in pregnancy, cancer, hemolytic anemia, or if a patient's taking a folate antagonist without folate, and that's like methotrexate. So clinical lab and findings are macrocytic RBCs with hypersegmented neutrophils. You'll see glossitis, cells of the tongue can't turn over as well. You'll have decreased serum folate, increased serum homocysteine, like I mentioned earlier, but a normal methylmalonic acid. And treatment for that is folate, okay? So megaloblastic anemia, another one, B12 deficiency. This is less common than folate deficiency. It takes years to develop with vitamin B12 deficiency because we have large hepatic storages of vitamin B12. Causes: number one, most common form of B12 deficiency is due to pernicious anemia. It's an autoimmune destruction of the parietal cells in the stomach that leads to intrinsic factor deficiency. Intrinsic factor is needed for B12 absorption in the ileum. So the autoimmune destruction of the parietal cells, you can't produce the intrinsic factor. Intrinsic factor is necessary for B12 to be absorbed. If you can't do that, you can't absorb it in the terminal ileum. Pancreatic insufficiency. You can't produce the protease to cleave the R binder. When our body first initially ingest B12, the salivary glands produce R binder. This R binder helps bring the B12 through the stomach, and then the pancreatic protease is cleave the R binder off the B12 in the small intestines. But if there's pancreatic insufficiency, you can't break off the R binder. And if you can't break off the R binder, intrinsic factor can't bind to B12, and hence the deficiency. Any damage or inflammation to the terminal ileum, example, Crohn's disease or Diphyllobatherium latum, these both decrease absorption from the terminal ileum because of damage to the terminal ileum. Dietary deficiencies is rare except for in vegans. Clinical lab and findings: macrocytic anemia with hypersegmented neutrophils. They'll have glossitis. They'll have subacute combined degeneration of the spinal cord. And this is due to an increased amount of methylmalonic acid accumulation in myelin of the spinal cord, and this causes degeneration in certain regions. You'll have decreased B12, increased serum homocysteine due to inability to convert homocysteine to methionine with B12, and you have increased methylmalonic acid. Methylmalonic acid requires B12 to convert to succinyl-CoA. If you don't have B12, you can't get to succinyl-CoA, and MMA is elevated, and this is what is the big difference that you don't see in folate. B12 absorption. So we already talked about it, but we'll just quickly go through it again. Dietary vitamin B12 is complex to animal-derived proteins like meat and eggs. Okay, when vitamin B12 enters the mouth, vitamin B12 attaches to the R binder, which is secreted by the salivary glands to help go through the stomach. Once B12 passes through the stomach, the pancreas will secrete proteases to break off the attachment of R binder to B12. While passing through the stomach, parietal cells, which are located in the body of the stomach, secrete intrinsic factor to pass through the GI tract. Once protease cleaves the R binder, intrinsic factor attaches to the B12 for absorption in the ileum. Without intrinsic factor, B12 cannot be absorbed. So now, the last of the megaloblastic anemias, orotic aciduria, inability to convert orotic acid to UMB with the de novo pyrimidine synthase pathway. It's a defect in UMP synthase. You'll have orotic acid increased and seen in the urine. It's an autosomal recessive disease. There's failure to thrive. They'll have developmental delay. It's a megaloblastic anemia refractory to treatment with B12 and folate. So if you see megaloblastic anemia and you're seeing that B12 and folate are not helping, then this could become a thought process. There will be no hyperammonemia versus ornithine transcarbamylase deficiency, which has increased orotic acid and increased hyperammonemia. Treatment is with uridine monophosphate or uridine triacetate to bypass the mutated enzyme. And now here we have the non-megaloblastic anemias, alcoholism, liver disease, drugs like 5-FU, RSC, ziduvudine. You'll have no hypersegmented neutrophils. You have no megaloblastic change in other rapid dividing cells. And one disease is Diamond-Blackfan anemia. There's congenital form of pure red cell aplasia. This differs from Fanconi, which is a pancytopenia. This is just the red cells. It's a rapid onset within the first year of life. It's due to intrinsic defect in the erythroid precursor cells. There's an increase in hemoglobin F, but a decrease in total hemoglobin. They'll have a short stature, craniofacial abnormalities, and upper extremity malformations. The triphalangeal thumbs, this is very important in up to 50% of cases. So now normocytic anemia. Almost done, guys. Keep pushing, okay? Keep pushing. This is the only way we can do this work is through hard work, all right? And there's only one way to do it, is just one slide at a time. So normocytic anemia, MCV equals 80 to 100. There's a decreased RBC mass. They're just normal size. The key differential diagnosis is getting the reticulocyte index. It will help differentiate between anemia due to underproduction or destruction. A normal reticulocyte count is 1 to 2%. Properly functioning bone marrow and presence of anemia will ramp up to greater than 3%. The reticulocyte count can be falsely elevated with anemia, however. You correct it by getting multiplying the reticulocyte count times hematocrit over 45. If this corrected reticulocyte count is greater than 3%, it indicates good marrow response, suggesting a peripheral destruction. If it's less than 3% marrow response, it suggests underproduction, and there's a problem with the bone marrow. Peripheral red blood cell destruction is divided in intravascular and extravascular hemolysis. Both will have good marrow responses. RBCs killed by the reticuloendothelial system, which the spleen, liver, lymph nodes outside of the blood vessel, will do a lot of extravascular hemolysis. So extravascular hemolysis involve RBC destruction by the reticuloendothelial system, macrophages of the spleen, liver, and lymph nodes. The macrophages consume the RBCs and break down the hemoglobin. Globin turns into amino acids to be recycled. Heme is turned into iron and protoporphyrin. Protoporphyrin will break down into unconjugated bilirubin. And if the unconjugated bilirubin is too much for the enzymes in the livers to conjugate it and to go into the gallbladder, then you have unconjugated bilirubin that builds up in the blood, and this will cause jaundice. Clinical and lab findings is anemia with splenomegaly, increased risk for bilirubin gallstones because you have increased hemolysis and there's increased conjugated bilirubin converting to bilirubin going to the gallstones. You have jaundice, and you have marrow hyperplasia due to the hemolysis. Intravascular hemolysis, on the other hand, is destruction of red blood cells within the vessels. When hemoglobin enters the blood from lysed red blood cells, haptoglobin tries to recycle the hemoglobin by attacking it and taking it to the spleen to be reprocessed. There's not enough stores of haptoglobin, so it will decrease fairly quickly. Clinical and lab findings, you'll see hemoglobinemia, hemoglobinuria, hemosideриnuria, and hemosiderin is due to iron buildup in the tubules of the kidney, and eventually those will slough off and they'll come off as hemosiderin in the urine, okay? And there's decreased serum haptoglobin because, like we said, the haptoglobin tries to recycle the hemoglobin, but there's not big stores of haptoglobin, so it'll decrease relatively quickly. So now we're talking about predominantly extravascular hemolysis. Here we have hereditary spherocytosis, okay? So it's an inherited defect of the RBC cytoskeleton membrane tethering proteins. Most common involve ankyrin, spectrin, and band3-1. A defect of the cytoskeleton will allow for blebs on the membrane to be formed. These blebs are removed by the spleen. Eventually, removal of the blebs will make the RBC round, spherocytotic, and not biconcave, which is disc-shaped. Spherocytes are not able to pass through the spleen sinusoids. They're consumed by splenic macrophages, resulting in anemia. Clinical and lab findings: spherocytes with loss of central pallor, increased MCHC, one of the only diseases that elevates MCHC. As cells shrinks, so let's say, what is MCHC? As the cell shrinks, the cytoplasm should remain the same. Hemoglobin will become more concentrated in cells. We'll see this with increased MCHC. You'll see splenomegaly, you'll see jaundice with unconjugated bilirubin, increased risk for bilirubin gallstones, increased risk for aplastic crisis with parvovirus B19. The diagnosis is with the osmotic fragility test, which will be positive, and we'll discuss that in the next slide. And the treatment is with splenectomy. It resolves anemia, spherocytes persist, and how jolly bodies will be seen on blood smearing. We'll also talk about what how jolly bodies are. So osmotic fragility test. You put the cells in a hypotonic solution. Normal biconcave red blood cells can accept outside water. The cell is flexible, they have the room to expand, and they will swell before they burst. But with hereditary spherocytosis, the cell has no extra membrane to expand and will burst easily once it's put in the solution, hypotonic solution. How jolly bodies. When the RBCs are born, the nucleus is removed. On occasion, RBCs can have a fragment of nuclear material that didn't get removed. Job of the spleen is to remove the extra fragments of nuclear material. When the spleen is removed, the process to remove these little fragments of DNA does not occur. Hence, how jolly bodies will be on a blood smear. So now let's talk about sickle cell, which is predominantly, excuse me. So it's an autosomal recessive disease, and there's a normal glutamic acid, which is hydrophilic, that's replaced with valine, that's hydrophobic. And this sickle cell is protective against Plasmodium falciparum malaria. So 10% of African descendants will carry this disease. It arises when two abnormal beta genes are present, alpha-2 beta-2 sickle. It results in greater than 90% HbS in RBCs. Hemoglobin S polymerize when deoxygenated and aggregate into needle-like structure, resulting in sickle cells. The banana shape. These sickle cells are what are causing so much damage to the microcirculation because they're not able to go back into their biconcave shape. There increased risk with sickling cells with dehydration, acidemia, and hypoxemia. Hemoglobin F protects against sickling. So the first few months of life, high hemoglobin F is protective. Cells constantly sickle and desickle while passing through microcirculation. This results in complications related to RBC membrane damage. This will lead to extravascular hemolysis, which will cause jaundice, anemia, increased risk for bilirubin stones. Intravascular hemolysis will have decreased haptoglobin. Sickling cells can eventually turn irreversible, leading to complications of vaso-occlusion. Labs. Sickle cells and target cells on blood smears, seen in sickle cell disease, not the trait, however. Metabisulfate screen. It causes cells with any amount of HbS to sickle. So you can see this in both sickle cell disease and trait. But the best test is a hemoglobin electrophoresis. It confirms the presence and amount of hemoglobin S. If you have sickle cell disease, you have 90% hemoglobin S, 8% hemoglobin F, and 2% hemoglobin A2. In sickle cell trait, you have 55% normal hemoglobin A, 45% hemoglobin S, and just 2% of hemoglobin A2. So that's a big differentiation. You should definitely know and recognize the differences between these numbers. And they're not always these numbers, but this is a ballpark, right? Treatment, hydroxyurea involves increases levels of hemoglobin F, and in an acute crisis, you'll give IV fluids, oxygen, and pain control. Morphine is okay in children. So some complications of sickle cell, dactylitis, swollen hands and feet due to vaso-occlusive infarcts of bones. This is the common presenting sign in infants, and this is how we can help make the diagnosis of sickle cell for children. Acute chest syndrome, vaso-occlusion in pulmonary circulation. The patient presents with chest pain, shortness of breath, and lung infiltrates, often precipitated by a pneumonia, and this is the most common cause of death in adults with sickle cell disease. There's pain crisis, vaso-occlusion in other areas of the bones, renal papillary necrosis, vaso-occlusion in kidneys, results in gross hematuria and proteinuria. And then autosplenectomy leads to shrunken fibrotic spleen, which increase the risk of infection with encapsulated organisms. Most common cause of death in children like H. flu and strep pneumo. Very important to vaccinate these children. And you have increased risk of osteomyelitis due to Salmonella paratyphi, and you'll see the how jolly bodies on blood smear. Sickle cell trait, presence of one mutated and one normal beta gene. It results in less than 50% of HBS and RBCs. It has a risk with the renal medulla, and if there's extreme hypoxia and hypertonicity causing sickling, there'll be microinfarctions that can occur causing microscopic hematuria, and eventually kidneys can't concentrate the urine. Here we have hemoglobin C. It's autosomal recessive. It's a mutation in the beta gene of hemoglobin, and the normal glutamic acid is replaced by lysine. It's less common than sickle cell, and it presents with mild anemia due to extravascular crisis. Hemoglobin C crystals are seen in RBCs, and hemoglobin C has to do with lysine, okay? Paroxysmal nocturnal hemoglobinuria. This is acquired defect in the myeloid stem cells resulting in absent GPI, renders cells susceptible to complement. Normally, there are two molecules that are attached by GPI to the cells, which are decay accelerating factor, DAF, and MERL, which is membrane inhibitor of reactive lysis. DAF and MERL are attached by GPI and is essential to express these molecules on the cell. When GPI is absent, platelet RBCs, white blood cells, will be susceptible to complement destruction. DAF and MERL avoid complement from binding to the cells. Complement is overly activated when the body is in an acidic state. When humans are asleep, the breathing becomes more shallow and CO2 is retained, causing respiratory acidosis. This will stimulate complement to bind to the cells that don't have GPI. This can cause intravascular hemolysis, and this will be seen in urine as hemoglobinuria. So that's why you see hemoglobinuria and nocturnal because of that respiratory acidosis. Screen. So we can use this sucrose test used to screen for the disease. It's confirmed with either the acidified serum test or the flow cytometry, which is the better test. And this will detect the lack of CD55, which is DAF, decay accelerating factor. The main cause of death is thrombosis of hepatic, portal, or cerebral veins. The destroyed platelets, right? Because we said that platelets can also be missing the GPI and they don't have DAF or MERL, and they release cytoplasmic contents into circulation, inducing thrombosis. The complications include iron deficiency anemia due to loss of iron in the urine from hemoglobin, or AML develops in 10% of patients, and this is because of the mutation in the myeloid stem cell. So here we have G6PD deficiency. It's an X-linked recessive disorder resulting in reduced half-life of the G6PD enzyme. It renders cells susceptible to oxidative stress. RBCs live in an environment of oxidative stress, so it's paramount to have a good amount of G6PD. To protect themselves from this, example, inflammation in the body or oxygen, our cells use a special molecule called glutathione. Glutathione protects against oxidative stress. When glutathione is presented to an oxidative stress, it sacrifices itself in order for the cell to function normally. However, once the oxidized glutathione is present, it needs to be reduced so that it can be ready to take the next oxidative stress. NADPH is used to reduce the oxidized glutathione back to reduced form of glutathione. NADPH is produced by G6PD. So overall, no G6PD, no NADPH, no way to form reduced glutathione. So this means the cells are more susceptible to damage because they have oxidized glutathione, and then their cells will don't have any protective form from the stress. Two variants: African variant, mildly reduced half-life of G6PD, and the Mediterranean variant, markedly reduced half-life of G6PD. Causes of oxidative stress: infections, drugs, primaquine, sulfa drugs, dapsone, TMP, SMX, okay? Fava beans. Oxidative stress precipitate hemoglobin as Heinz body. Heinz bodies are removed by splenic macrophages, resulting in bite cells, causes intravascular hemolysis. And this will they present with hemoglobinuria and back pain. Screen with Heinz bodies, and you confirm disease with enzyme studies. So now, immune hemolytic anemia, okay? So antibody-mediated IgG or IgM destruction of RBCs. The Coombs test is very important. It's used to diagnose immune hemolytic anemia. It can be direct or indirect. So first we'll talk about direct Coombs test, okay? IgG warm, asking, are antibody-coated RBCs present? So first, we confirm the presence of antibody-coated RBC. Second, anti-IgG is added to the patient RBC. Third, agglutination occurs if RBCs are already coated with the IgG antibody, and this is the most important test for the immune hemolytic anemia. The indirect Coombs test is asking, are there antibodies in the serum? So we'll confirm the presence of antibodies in the patient's serum. Anti-IgG and test RBCs are mixed with the patient's serum. Agglutination occurs if the serum antibody is present, okay? So now IgG mediated immune hemolytic anemia. It usually involves extravascular hemolysis. IgG binds RBCs in the relatively warm central body. Membranes of antibody-coated RBCs is consumed by splenic macrophages, and this will result in spirocytes. This is associated with SLE, CLL, and drugs like penicillin and methyl-dopa. The treatment is cessation of the offending drug, give steroids, give IVIG, and splenectomy. IgM-mediated immune hemolytic anemia, it usually involves intravascular hemolysis. It binds to the RBCs and fixes complement in the relatively cold temperatures of the extremities. This is called cold agglutination. It's associated with mycoplasma pneumonia and infectious mononucleosis. Here we have microangiopathic hemolytic anemia that result from vascular pathologies. RBCs are destroyed as they pass through the circulation. So there's little microthrombi that are formed due to a couple of these causes, and they will cause schistocytes because they will actually shear the red blood cell as they're trying to go through the micro circulation. Causes: thrombotic thrombocytopenic purpura, and this is a platelet thrombi, patient like Adam TS13. Hemolytic uremic syndrome is due to E. coli toxin 0157H7. DIC is a platelet and fibrin thrombi. HELP causes pregnancy, elevated liver enzymes. Microthrombi produce schistocytes on blood smears. Other causes: a prosthetic heart valve. When the blood is trying to get through a prosthetic heart valve or aortic stenosis, it could damage the cells, and this could cause hemolysis. Malaria, what it does is it infects the RBC and liver with plasmodium. Hemolysis is caused by the RBC rupture as a part of the plasmodium life cycle. It results in intravascular hemolysis and cyclical fevers, especially for falciparum, which is worse, and there's fever every day. Vivax and Ovale have fever every other day. There's also extravascular hemolysis causing splenomegaly. Guys, thank you for your time. Remember, there is no substitute for hard work. Hard work always pays off. What we study today may not show up today, but you trust that hard work you do today will pay off when you need it the most, okay? Success is not final. Failure is not fatal. Always remember this. It is the courage to continue that counts. We all have a lot of courage. We've all been on a long journey. Just put a little more effort, make your belief stronger than your doubt, and you could do this, okay? See you guys at the top of the rock and in the next video. Thank you so much. If you have any questions, contact me at amartej@acemedwars.com. Thank you.